All right, welcome to part 4. Let's continue on. One of the most common emergencies that you'll be called to for a pediatric patient is a respiratory emergency. So we're going to spend a lot of time talking about these sorts of emergencies. Failure to recognize a respiratory emergency in a child will lead to death. Respiratory failure and respiratory arrest are the #1 cause of cardiac arrest in children. Adults have cardiac arrest because they have heart attacks. Kids go into cardiac arrest because of a respiratory problem. So any patient that is working harder to breathe, left on their own, will eventually go into respiratory failure if left completely untreated. Initial stages of hypoxia and respiratory distress can result in combativeness, a restless or anxious patient, or somebody that is aggressive. So look for signs and symptoms, increased work of breathing. Look for those retractions. Look for sounds. Look for adventitious lung sounds. Listen for stridor. Can you hear wheezing even without your stethoscope? And look for any signs of respiratory failure. Respiratory failure means their respiratory system has failed and their effort to breathe will start to decrease, but their respiratory overall picture will also go down. So just because they're not working at breathing quite so much anymore doesn't mean that they're getting better. It may mean that their body is giving up. Okay? Look for less chest rise with their inspiration. Look for changes in behavior and altered mental status. So, as respiratory failure progresses, you will see periods of apnea. You will have hypoxia begin to set in, and this is particularly important to the heart. So as the heart muscle becomes hypoxic, you get cardiac dysrhythmias, and they may go into cardiac arrest. Okay? Remember that respiratory failure does not always indicate a respiratory disease or obstruction. It can be trauma. It can be pulmonary contusion. It could be metabolic disturbances. It could be neurologic problems. It could be dehydration and even cardiac contusion to a certain extent. So anytime you go from respiratory distress to failure is a bad thing. So make sure that you're keeping an eye on patients that are in respiratory distress so that we can help stop them from going into respiratory failure. Remember that a child needs twice as much oxygen as an adult does. So they will need higher levels of supplemental oxygen to keep their oxygen sats up and to meet their metabolic demands. Anytime you have a patient in possible respiratory failure, when possible, assist their ventilation with the BVM and pure oxygen. Okay, 100% oxygen, high flow, just crank it up, let the BVM inflate, and go for it. Making sure not to hyperventilate them or ventilate too much. Okay. While you're still on scene, make the patient as comfortable as possible, and also make them as comfortable as possible during transport. As I mentioned earlier, airway obstruction is a big deal when it comes to kids. Their airways are much smaller. See drinking straw analogy for infants. And like I explained before, they observe their world with their mouth and lips. So anything that a child can fit into their mouth can be an airway obstruction. Children should not be chewing on things like this. Candies, buttons, small toys. See that army man sitting back there. Coins, rubber ducks. Okay? Children should be observed when they're playing and not just left alone with this because they might swallow it or inhale it either intentionally or unintentionally. Of course, anytime that you have a traumatic incident or anything that's causing them to bleed, vomit, have mucus or other secretions, those in themselves will cause an airway obstruction if there's too much of them. So you think about it anytime you see a patient that's drooling, anytime they have signs of a cold, if they're congested. Croup and epiglottitis are two big things that we have to look out for in pediatrics, especially croup. And then RSV is a virus that is very common in children during cold and flu season. This is a virus that infects their respiratory tract and can cause all of these as well. So you can have foreign objects involved in both their upper and lower airways. If it manages to get into their trachea and into their lower airway, that's much harder to deal with. If it's in the upper airway, the child may be able to spit it out. You may be able to pull something out if it's big enough and visible. But if it's in the lower airway, there's nothing we're going to do about that. So listen to their airways. Do you hear crackles? Do you hear rhonchi? Do you hear wheezing? Do you hear decreased lung sounds on one side or the other? Do you hear stridor? Listen to the lungs at armpit level on both sides of the chest. Okay? This can help you differentiate between size. I mentioned back in part 1 that their lungs and their chest walls are thinner, so it can be harder to distinguish right from left. So go on either side of them to determine which side you're actually hearing sounds from. If there is an airway obstruction, we have to treat it rapidly. Left untreated, this is something that will cause them to go into cardiac arrest. Use your basic maneuvers. If someone is able to cough and move air, encourage them to cough. Encourage them to cough hard to try to clear the airway obstruction. If you see signs of a major airway obstruction, try to clear it immediately. For an infant, you're going to do those back blows and chest thrusts, just like you learned in your CPR class. Your 5 chest thrusts and then 5 back slaps, alternating back and forth until a patient either dispels the object or goes unconscious. A complete airway obstruction is a child, and not in an infant, a child, is something that you need to treat with abdominal thrusts, aka the Heimlich maneuver. Okay, you learned how to do those in your CPR class. Use your head tilt chin lift and a finger sweep to remove a visible, an emphasis on visible as you see it in here, a visible foreign body from their mouth. If you can't see it, don't go searching for it. Only visible ones should be removed with a finger sweep. If they go unconscious, then we're going to use chest compressions because they're probably going to code, and even if they hadn't, doing these chest compressions can help relieve a severe airway obstruction in those cases. So back slaps, chest thrusts, abdominal thrusts, all for patients that have a complete airway obstruction and are alert and awake enough to allow you to do that. If they're unconscious, then we're going to go to chest compressions. Asthma is a very common respiratory ailment. This is a condition where the lower bronchioles become inflamed, they swell up, they get plugged with mucus, and this leads to them not being able to conduct air. This is the classic presentation of wheezing that you'll hear from these patients. It's a very common 911 call. If they know they have asthma, they probably have some form of rescue inhaler. Where we get into problems is if their rescue inhaler isn't with them, they haven't used it, or if they've used it to no effect. That means that this is a much more severe asthma exacerbation and needs to be treated quickly. So what can cause asthma? What are the common causes? Colds, asthma, of course, colds, flu, allergies, smoke, dust, dog hair, exposure to new environments, cold air even sometimes can cause the bronchioles to constrict. These are patients that will have wheezing. They will have hypoxia, very strong work of breathing. They may be panicked, especially if they're not around their medication, or let's say this is their first time having an asthma attack and they don't have a rescue inhaler. That's where we come in. Our treatment for these revolves around giving beta blockers. You can assist beta agonists, that will relax the bronchial smooth muscle. In severe cases, we can actually give them epinephrine as well, but at the EMT basic level, what you're looking at is to assist someone with their own albuterol inhaler. And here in New Mexico, you can, of course, give an albuterol nebulizer as well. Pneumonia is the leading cause of respiratory death in children. Pneumonia is a general term that refers to any infection of the lungs. It can be from a bacterial source, it can be from a viral source, it can be from a fungal source even. The presentation for kids can be quite varied. Generally, they will be sick, they may have a fever, they may have a decreased level of consciousness, they may have all these various respiratory symptoms. They may or may not have wheezing, but you may hear the sounds of fluid accumulation in their lungs. You may hear those rales and rhonchi. You may hear a popping sound like fluid moving through water when you auscultate their lungs. We don't diagnose this, we can suspect it, but diagnosis of this requires blood cultures and chest x-rays at the hospital. So croup is an infection of the airway below the level of the vocal cords. Most of the time it's caused by a virus, though occasionally it can be caused by a bacteria, but most of the time it's viral. The most common ages that we see this are between 6 months and 3 years of age. And unfortunately, it's quite easy for a child to pass to another. So if a child goes to daycare or to school or goes around other children while they have croup, the chances are it will start to go through that area. So you'll see runs of croup going through child care centers, daycares, and schools, even if just one kid had it initially. The hallmark signs are stridor. Severe croup will produce stridor, and a seal bark-like cough is what it calls it. So that deep, almost seal-sounding cough that they will have. It's very characteristic. Treatment for it revolves around, well, oxygen primarily, and then if they have wheezing, you can give them albuterol. All the way up to, in some cases, some places will even allow epinephrine, but that's generally not the primary treatment. At the EMT basic level, we need to focus on oxygen and use of any inhaled medications. Epiglottitis is specifically a bacterial infection of the epiglottis, the area around and above the vocal cords. We have seen less of this since the development of vaccines for these bacteria, but it still happens. The problem that occurs with this is that the epiglottis starts to swell. And as the epiglottis swells up, it's sitting there at the back of your throat, back of your airway, and it is the flap that covers your trachea and vocal cords. When this swells, it can be very difficult for them to breathe because it will start to occlude the airway. And one of the dangers here is that when a child has epiglottitis, if the epiglottis or uvula is touched, that can trigger that swelling. So if they put something in their mouth, or you try to stick something back there, or even if they just move around too much and that epiglottis swells and expands suddenly, it can actually completely cut off their airway and lead to respiratory arrest. So these patients are going to look sick. They're going to have a history of a sore throat. They're going to have a high fever. One of the hallmarks that you're going to see is they're going to be sitting forward, they're going to be tripoding, and they're going to be drooling. So anytime you have a patient, especially a child, that is sick with a respiratory illness, either reports a sore throat or you can tell that they would, and are drooling, especially drooling, you should consider epiglottitis. Don't stick anything in their mouth. Transport them rapidly. Bronchiolitis. I mentioned RSV at the beginning. It is a very common respiratory ailment in children and toddlers, especially newborns and toddlers. They get this virus, the RSV virus, and it causes them to produce copious amounts of secretions in their airway. Eventually, it will cause dehydration, shortness of breath, fever. It can cause hypoxia and pneumonia. It is more common in premature infants. So just make sure you're taking a good thorough history of the patient and getting good demographics and asking those questions of the parents, the caregivers, and they may get RSV every year. There are kids that do this. This just happens to them every single year, and the parents may know that. Make sure you're asking those questions. Whooping cough is a bacterial spread illness that we do vaccinate for, but we are seeing a resurgence of this thanks to anti-vaccination movements. It is very easy to spread because it is respiratory and it is spread in droplet form. So when they're coughing, because that's one of the primary symptoms of this, they are spreading that disease. It is something that adults can get as well, though it is more common in children. Keep their airway open. Transport them quickly. Put a mask over them to help keep the spread of that down. Make sure that you are following standard precautions, wearing your PPE. Not only do you put a mask on them, but you should also be wearing proper mask isolation like an N95 because pertussis is particularly contagious. Make sure your vaccines are up to date. If you have not been vaccinated, you need to be vaccinated. All right. So when it comes to managing the airway itself, We have several things that we can use to help an artificial ventilation. So we've got our NPAs and our OPAs. All of these work the same way in children as they do in adults. They keep, especially the OPA, keeps the tongue from blocking the airway, makes it easier to suction, but make sure you're using the right sized OPA for the patient. You're still going to measure it in the same way, okay? Earlobe, corner of the mouth, or jaw. All right. These should be used in patients who are in respiratory failure and unconscious, because if they have a gag reflex, you're going to cause them to vomit, and adding aspiration on top of existing respiratory failure is a recipe for disaster. NPAs are usually more easily tolerated. I prefer them over OPAs because they're easier on the gag reflex. You can use these on more responsive patients, all the way up to fully responsive patients, though you may have a hard time with younger children convincing them that you're going to stick this plastic tube down their nose. So use this anytime that you need an airway adjunct, respiratory failure, respiratory arrest, of course. We don't generally use them in patients less than a year old. We don't have the correct sizes for them. And we should not be using them, just like with an adult, if there are nasal obstructions or head trauma, because the problems that they can cause, there have been cases of them going back into the skull if there's fracture. And of course, if the nose is obstructed, you're not going to be able to get the NPA back in there, and you're not going to shove stuff out of the way. That can cause trauma and bleeding. As far as oxygen goes, we have several options, and a lot of this will depend on how cooperative and how old your patient is. So blow-by oxygen, generally we use this at 6 liters per minute or more, and it provides oxygen concentrations roughly the same as atmospheric. So about 21% oxygen concentration is what gets to the patient. This can be enough to pop their sats up. So if their sats are soft, if they're just kind of low, maybe they're in the 80s, something like that, sometimes just giving an increase in oxygen through blow-by will pop their sats back up to the 90s. And on young children, especially if you don't have the stickies that go on their face to help hold cannulas in place, it might be your only option, because a smaller child is also probably not going to tolerate a non-rebreather mask over their face. One of the easiest ways that I found to do this, especially if the child is not cooperating well, is have mom or dad, if you're on scene, hold the infant, hold the child, and hold the oxygen mask at the same time. They'll usually be more comfortable with that. During transport, obviously, we're not going to be having mom or dad hold the child. They need to be properly secured, but put that blow-by their face, and it will increase their local oxygen enough that you can get some benefit. A nasal cannula between 1 and 6 liters per minute can provide anywhere from 24 to 41% oxygen concentration, depending on the type and the flow rate that you're using. These are usually more easily tolerated by younger children, as long as they don't mind having those prongs in their nose and the feeling of oxygen blowing up their nose. That can be a problem. Of course, non-rebreather masks, those provide much higher concentrations of oxygen. And the BVM, if you're BVMing with supplemental oxygen, it's pretty much 100% oxygen concentration. Make sure you're using oxygen wisely. Not every patient needs oxygen, but don't be afraid to use it if they're hypoxic, if they're in respiratory distress, breathing more than 60 times a minute, if they're altered, if they have an inadequate tidal volume for whatever reason. Use your BVM with that oxygen as tolerated. It might not be even when they're completely in respiratory arrest, but you can assist, especially a patient that has an altered LOC, you can assist their ventilations and help their body out by bagging them, even if they're not apneic. So we talked about blow-by. It doesn't provide as high concentration of oxygen, but if it's what you've got, it's what you've got. And if that's all you need, great. If it's working and you're getting your oxygen saturations up to where you need to be, perfect. Okay. So here are a couple of different options that you can use for blow-by. You see over here on the right-hand side, they've actually poked a hole in the bottom of a cup and have the oxygen tube going through. This is kind of mask-ish. It allows blow-by. There is space in here. Okay, this is not up all the way against his face, but this is providing a concentration of oxygen for him to breathe. Of course, hopefully we all recognize this as a nasal cannula. Again, choose your oxygen delivery device based upon the situation present. Do they need respiratory support? If so, pick a BVM. If they just need oxygen support, your non-rebreather, your cannula, your blow-by, you'll just have to pick depending on how much oxygen they need, their age, and if they're going to fight you. Okay. Kids generally do not like, you can see this young man looks like he's not particularly happy. A younger child that does let you put a mask on them, though, that can indicate pretty severe respiratory distress, especially if they don't care about that mask fitting over their face. If they're less caring about things like that, be afraid, because they're getting tired. Their breathing is probably about to get worse. When all possible, you should be using a BVM with 2 rescuers. There's one person to hold the mask and hold the head, and there's one person to do the bagging. Okay. All right, I will see you guys in the next section.